In developed nations, sevoflurane is the preferred inhaled anesthetic. It has almost entirely replaced older agents like halothane as the modern standard of care. It provides smooth inhalation inductions, specifically for pediatric patients and uncooperative adults when intravenous access is difficult. This high clinical utility relies on two specific physicochemical properties: a complete lack of pungency and extremely low solubility in blood. To understand how to safely deploy this drug, we need to map its exact profile across 6 clinical domains: pharmacology, pathophysiology, biochemistry, guidelines, dosage, and scenarios. Mastering sevoflurane requires understanding how the molecular structure of a fluorinated ether dictates every physiological outcome in the operating room. Chemically speaking, sevoflurane is a fluorinated ether. It possesses a modest vapor pressure, conveniently allowing anesthesiologists to deliver it using a conventional variable bypass vaporizer. The behavior of any inhaled anesthetic is largely determined by its blood-gas partition coefficient, denoted clinically as lambda B to G. This visualization compares the solubility ratios of 3 common agents. Desflurane is the least soluble at 0.42. Isoflurane is highly soluble at 1.4. Sevoflurane sits in between, with a coefficient of exactly 0.65. This mathematically low solubility translates to clinical speed. The blood resists absorbing the gas, so alveolar concentration rapidly equilibrates with inspired concentration, creating a steep FA over FI curve. As this spikes, it crosses the threshold for loss of consciousness, producing an exceptionally fast induction. That same low solubility also works in reverse. It drives a much more rapid washout and emergence at the end of a case, compared to a highly soluble agent like isoflurane. Pharmacodynamically, crossing this threshold results in a predictable state: reversible loss of consciousness, profound amnesia, analgesia, and muscle relaxation. At the synaptic level, it interacts with central nervous system ion channels, activating inhibitory GABA receptors and blocking excitatory NMDA receptors. The physical resistance to blood absorption is the exact mechanism that grants the anesthesiologist rapid, precise, and highly reversible control over anesthetic depth. Systemically, the drug creates a distinct hemodynamic and neurophysiological footprint, starting with the cardiovascular system. Sevoflurane mildly depresses myocardial contractility. As a direct result, both systemic vascular resistance and mean arterial pressure will decline slightly. Crucially, unlike isoflurane, sevoflurane causes almost no compensatory rise in heart rate. Without that chronotropic response, overall cardiac output is decreased. It can also prolong the QT interval, a specific manifestation that may appear up to 60 minutes following anesthetic emergence in infants. In the central nervous system, we see a distinct uncoupling of cerebral metabolic demand from cerebral blood flow. This table outlines the comparative physiological effects of various anesthetics on the brain. Focusing on the sevoflurane row, 3 downward arrows in the CMR column indicate a significant decrease in cerebral metabolic oxygen rate. However, adjacent columns show slight increases in both cerebral blood flow and intracranial pressure, provided the patient remains at normal carbia. Administering high concentrations of sevoflurane, exceeding 1.5 mAh, can impair the brain's innate ability to auto-regulate that blood flow. Moving to the respiratory system, it acts as a potent bronchodilator, effectively reversing active bronchospasm. In the liver, it decreases portal vein flow, but proportionally increases hepatic artery flow, ensuring total hepatic oxygen delivery remains completely maintained. Sevoflurane is not hemodynamically neutral. Utilizing its induction benefits requires proactive management of depressed cardiac output and altered cerebral autoregulation. There is a biochemical paradox at the center of sevoflurane administration. The drug undergoes heavy metabolism and yields known toxins, yet maintains an exceptional clinical safety record. Hepatic metabolism is driven by the liver enzyme P450, specifically the CYP2E1 isoform, processing the drug at an overall 5% rate. This chart compares metabolic rates. At 5%, sevoflurane is metabolized 10 to 25 times more extensively than isoflurane or desflurane. This heavy metabolism generates inorganic fluoride ions. Some patients exceed threshold levels historically linked to theoretical nephrotoxicity. Yet the clinical reality is absolute. There is no clinically significant kidney dysfunction associated with sevoflurane anesthesia in humans from fluoride accumulation. A secondary biochemical risk originates externally, inside the physical hardware of the anesthesia workstation itself. When sevoflurane interacts with alkali carbon dioxide absorbents like barium hydroxide or soda lime, chemical degradation produces compound A. Its accumulation accelerates under specific environmental drivers within the circuit: high respiratory gas temperatures, low-flow anesthesia, desiccated absorbent, and long-duration cases. While compound A causes proven nephrotoxicity in laboratory rats, extensive human trials show a distinct discrepancy, revealing no detectable postoperative renal injury in human subjects. The biochemical degradation pathways generating fluoride and compound A are highly active, but human physiological tolerance renders them clinically insignificant when the anesthesiologist manages the gas properly. We can now translate these biochemical and physiological principles into strict clinical protocols. For pediatric and uncooperative adult inductions, the standard dosage is 4 to 8% sevoflurane, delivered in a 50% mixture of nitrous oxide and oxygen. Due to the low blood gas partition coefficient, this specific mixture reliably achieves a smooth loss of consciousness within 1 minute. During maintenance, sevoflurane provides adequate muscle relaxation on its own, but clinicians typically supplement it with neuromuscular blocking agents, which the gas strongly potentiates. To definitively mitigate the accumulation of toxic compound A during maintenance, clinicians rely on one primary mechanical guideline: fresh gas flows must be maintained at a minimum of 2 liters per minute for any anesthetic lasting more than a few hours. Finally, absolute contraindications for sevoflurane administration include patient susceptibility to malignant hyperthermia, severe patient hypovolemia, and severe intracranial hypertension. Safe administration is an exercise in balance. The clinician leverages its rapid induction benefits while neutralizing its vasodilatory effects and compound A risks through strict dosing and fresh gas flow limits. Sevoflurane represents a triumph of ideal pharmacokinetics over theoretical biochemistry. Its non-pungency and low blood solubility maintain its unrivaled status for rapid inhalation inductions in modern anesthesiology. The clinician accepts specific physiological trade-offs to gain this control, primarily anticipating decreased cardiac output and carefully managing cerebral uncoupling. They must also respect the chemical realities of the closed circuit, defeating compound A accumulation by simply keeping fresh gas flows above 2 liters per minute. Mastering sevoflurane from A to Z elevates the clinician from a mere administrator of gas to a precise, informed modulator of systemic human physiology.